We've talked about segmental facilitation previously, but more or less in passing. We've never actually gone into it in any detail, and I'm going to try and rectify that with this presentation. Previously, in the previous modules, it's never been that an important concept. Coming to the last four, it becomes very important as far as etiology is concerned. So hence, we're going to spend more time with it now. It's a neurophysiological state, and I'll explain how it comes about in a bit. It can confuse the diagnosis, and it can actually cause dysfunctions. So it's as well to understand what we're doing with this in some detail. There's a wealth of information in your syllabus. Dave will have access to all that, and you're getting access to it as well. Take the time to work to read this. This and reflex inhibition are going to be two concepts that are going to be very, very important to the next four modules. Okay, so segmental facilitation or facilitated segment, it's a form of central sensitization, essentially. And basically, the segment has its response threshold lowered by aberrant input, prolonged aberrant input. And so the response is much higher than it would be normally. Now, this actually comes in two flavors: normal facilitation and pathological or dysfunctional facilitation. Normal facilitation is a training effect. If I do the same movement over and over and over again, then the segments involved in that movement, the signal through them becomes easier. Facilitation means to make it easier. So it's an easier response. And so it's not exaggerated, but the whole thing is smoother, if you like. Dysfunctional or pathological facilitation is not that. This is an exaggerated response, highly exaggerated, so that the changes in the response can actually be seen by an outside observer and cause detrimental effects. So there's a very complex definition of segmental facilitation, which is also going to be in the materials. Have a look at it, but don't get too bound up on it. Now, the facilitation occurs in the sensory system, the motor system, and the autonomic system on the lateral horn. So that's facilitation. Now, as to cause, I said it was aberrant input, and most people would quote that as the cause of it, which would include nociception and proprioception, abnormal proprioception, over a prolonged period. Now, what that prolonged period is, I have no idea. It probably got to do with something to do with the intensity of the stimulus. Much the same as referred pain is a multitude of factors going into it, but it is over a prolonged period. Now, as far as it being caused by aberrant proprioception, we know that inadequate proprioception leads to reflex inhibition, which is almost the opposite of segmental facilitation. So it's difficult to see how inadequate proprioception can cause facilitation when it causes the opposite. So I think you can rule that one out. Excessive proprioception, outside of some neurological conditions, maybe Parkinson's, I can't see how you would come around to ever coming across that. Hypermobility will not give you more proprioception. In fact, it's probably going to give you less. If you think about it, what we've done is increase the joint range, but not increase the proprioception. In fact, the proprioception may well have been reduced by the attenuation of the capsule and the ligaments. So again, you're going to end up with inadequate proprioception, not too much of it. Instability is definitely going to reduce proprioception, as will hypomobility. So it's difficult to see how proprioception can play a role in segmental facilitation. Nociception, on the other hand, yes. Nociception is not synonymous with pain. We tend to think that way, but it isn't. So you can certainly have nociception, not have pain, and you can have painless nociception causing segmental facilitation. So during the examination, to see where the nociception is coming from that might be causing this, then you're going to have to see if you can make the tissues go from nociception to pain perception. If you can do that, then you've got a fair crack that this joint is involved in the proprioception, in the facilitation, and it makes it a fair target. So from a purely practical perspective, if we get rid of proprioception entirely as a cause of facilitation, it makes the finding of the cause facilitation that much easier, but it is complicated by one thing. First off, the cause does not have to be in the spinal segment. Now, segmental facilitation does not refer to the spinal segment. It refers to the neurological segment, not the joints, not the bone, not the ligament, just the spinal segment gets, the neurological segment becomes facilitated. That gets mixed up by a lot of people, that the cause of the facilitation must be coming from the spinal segment, that is the joints or the ligaments or the bone. And that's absolutely not true. The input has to be from somewhere, from a tissue that's derived from that segment, and that segment is basically supplying. So this can be anywhere along that myotome, dermatome, sclerotome. Come to that. It doesn't have to be in the spinal segment. That's really an important point to remember, and it gets forgotten all the time. So just bear that in mind. Okay, as far as effects, these are distributed in a segmental pattern, and the effects are more profound closer to the spine than further away from it. So, for example, if you're looking at a scratch test to see if there's facilitation, you do it along the side of the spine, you don't do it down in the periphery. On the other hand, we can put in proprioception from anywhere within that segment and see if we can defacilitate that facilitation, that facilitated segment. So going one way, it can reduce it, is anywhere within that segment. But going the other way, the cause doesn't have to be in the spinal segment. Okay, so effects. Striated muscle, normal skeletal muscle becomes hypertonic. Now let's get this clear, the difference between hypertonicity, spasm, and spasticity. First, spasticity is a neurological state, is a startle reflex that's prolonged. So if you startle a patient who is prone to spasticity, they will become spastic and they will stay that way for some time. Again, variable amounts of time. Spasm is an on and off involuntary contraction of the muscle to protect the tissue that's causing the spasm. So for example, if I've got a joint that's inflamed, when the joint tries to move into its aggravated position, which is usually towards the close pack, where you get least volume, tighter ligaments and everything else, but that tends to be the aggravated position. And so as the joint moves into that position, the muscles that will pull it out of it and prevent it getting that range go into spasm. And the spasm is dependent on the speed of the movement that's triggering the spasm, and also the intensity of the pain being generated. So you're going to get hypertonicity rather than spasm. And hypertonicity is a steady state. It sits there as it is, and presumably it's caused by the signal from the intrafusal fibers being misread as too high. So the extrafusal fibers contract more strongly to take the stretch off the intrafusal. That's presumably the way this thing works, but it's a steady state and the muscle can still contract within that steady state. But the muscle contraction is abnormal. So if we just look at what the hypertonicity can do, it can reduce the range of motion. Now, whether this is particularly significant or not is open to debate as a loss of range. It can certainly confuse the diagnosis. So if you believe in adaptive shortening, which I think it doesn't make any real sense at all, then presumably this could also lead to adaptive shortening of the muscle. And if you want to find out my views on adaptive shortening, I'm going to give it to you anyway, what the hell. Adaptive shortening is where the muscle structurally changes and shortens, contractures form because it's not moved through its full range on a regular basis. The fact is, almost nobody, without deliberately stretching this, moves through the muscle through its full ranges on a regular basis. You work within the middle range where it's most efficient. That still doesn't lead to contraction, otherwise we'd all be sitting there like that. If you cast two joints, one's been damaged and the other one hasn't, but you have to cast to stabilize the other. When the cast comes off, the joint that wasn't damaged and so had no exudate and adhesions form around it mobilizes very quickly. They don't even need you to do it. The one that doesn't mobilize is the one with exudate and adhesions, and that is not adaptive shortening, that's traumatic scarring and adhesions. So I don't really see adaptive shortening being a major issue. I think what could be a major issue as far as etiology is concerned, though, is that the hypertonic muscle will act as a dynamic ligament, if you like. So it will change the axis of rotation of the bone, and it will set up abnormal shear and torque forces, and this could lead to damage to the joint. Hypertonicity presumably can also lead to muscle fatigue. The muscle is contracting more vigorously all the time, so presumably it fatigues out. And this continuous contraction can actually become a little bit ischemic in the muscle because it's closing down on the small blood vessels, and that can give you tenderness. In fact, I'm prepared to bet you that trigger points are areas of segmental facilitation. And then all of this can certainly lead to a misdiagnosis, increased tenderness, pain on contractions, and so on. All of that can cause confusion to the diagnosis. Smooth muscle hypertrophy is vascular, so we get hypertonus, and you end up with reduced blood flow. So one of the diagnostic effects of this is a reduced scratch reflex. If you scratch down the paravertebral muscles, you'll see an area where there's facilitation along them that doesn't redden, or it ends up with a very narrow band in there and comes out. This reflex can be very fast, so you have to watch for it quickly because it can go red again pretty quickly, but you'll see it there, and it actually tells you which segment it is as well, which is quite nice. That reduction in blood flow, both to and from the muscle, actually can lead to trophodema. I used to have a slide that I stole off somebody, and it had pictures of somebody pressing a matchstick, a wooden matchstick, into an area of skin, and there was actually persistent pitting edema showing. Somebody stole that bloody slide off, and you can't trust anybody anymore. But that's trophodema. You get orange peel skin from this. If you bunch the skin up, it looks like an orange peel. With weight problems, then you tend to see that with cellulose in the skin. I'm not sure what this is caused by, to be honest with you, but it's an observation. Not particularly important, I don't think. Muscle ischemia from the hypertonus, plus the possible ischemia from the vascular hypertonus, plus the ischemia from the muscle hypertonus, can end up with fatigue and tenderness and all the other stuff. So again, this can help with diagnostic confusion and not help with the actual diagnosis. The muscle gets weak. This is almost certainly because of neuromuscular incoordination. Again, the proprioceptive input being misread and the muscle overreacting or underreacting, but it ends up being weak. And of course, it's a segmental weakness, which can again confuse the diagnosis for a radiculopathy. But this is non-fatigable weakness, and you'll have all the other signs going along with this tenuous segmental facilitation. The other thing you can do, if you're not sure whether you're looking at fatigable or non-fatigable weakness, is wobble. More proprioceptive input into the segment, and if the strength rapidly improves, it's definitely not neurological. Let's see what weakness can do here. First off, it can increase the neutral zone, so it loses dynamic stability, so the neutral zone gets bigger, and then you get this negative feedback loop kicking in with reflex inhibition because of that, and you end up with an end zone instability as well. The weakness can lead to degenerate tendinopathies and degenerate muscle tearing, and again, as I said, there's a diagnostic confusion to concern yourself with. Hyperesthesia, this usually shows up as tenderness in the muscle, tenderness in the tendon, and sometimes pain on contraction, all of which can confuse the diagnosis. Sometimes, though, this will show up as dysesthesia. So if you test with pinprick, particularly with pinprick, if you run a pinwheel over the area, instead of it being prickly, it'll be prickly and tingly, so you get that dysesthetic That shouldn't confuse the diagnosis too much because you're not losing sensation, but it can confuse you as far as the tingling is concerned. And also brisker deep tendon reflexes. These are not hyperreflexive. There's no clonus in this. It's a normal reflex. As far as the quality of it is concerned, it's just that it's brisker than it would normally be. This can lead to diagnostic confusion until you think about it. You've got increased deep tendon reflexes in a radicular pattern. What upper motor neuron condition can do that? But as I say, there's no clonus in it, and it's not really as bad as an upper motor neuron hyperreflexia would actually be. We'll look at the examination for segmental facilitation when we've covered reflex inhibition and axoplasmic flow. So there is a neurophysiological examination that's going to be part of your process, and as well as looking for this stuff during for etiology searches. You don't always do the neurophysiological examination if you simply treat an egg joint, but if you're going to, there is a particular way of doing this. You need to do the neurophysiological exam before you have to do the passive mobility exams, simply because you tend to defacilitate and uninhibit those two, reflex inhibition and segmental facilitation, when you wobble the joint around. So we'll cover that in due course after I've covered the basics of reflex inhibition and axoplasmic flow. So as far as treatment is concerned, the principle is treat the cause. As I said, segmental facilitation isn't a diagnosis. It's not a pathology. It's just a collection of signs and symptoms, neurophysiological signs and symptoms that are part of the whole collection of signs and symptoms of that particular condition. So you don't treat the facilitation, you treat the cause of it, with the exception of the hypertonicity in the muscle, because this can prevent you from treating the joint, mobilizing it, manipulating it, stretching even. If there is a lot of hypertonus present, then it's going to restrict your ability to get at the root cause of the facilitation. So assess, treat the cause, and locally, if you want to defacilitate, you can use any of the treatments you think about. TENS will do it, passive movements will do it, generalized passive movements, particularly when they are a bit more specific to the segment. Active movements, not so much. Massage, yeah, but it's a long-winded process. Heat can reduce the tone and so on. Traction, wobbling is the big one. Wobble it, particularly in spinal segment, but you have to wobble the segment itself. It's no good really wobbling above or below. All of that will help defacilitate and get you to the point where you can actually do an effective treatment on the joint. So segmental facilitation, a very short summary of it, enough to be going on with though, but as I say, you need to look at this in a little bit more detail than you've got here. This is no substitute for you reading on this subject. Hope it helps. Hope it helps you. You need to start looking for it straight away, just so you can start looking for it and getting used to recognizing it when you see it. And we'll talk again. Take care, everybody. Bye-bye.